Hi, everyone. Thank you so much for joining us today. We're going to get started in about 1 minute. Give folks another second or so to jump on, and then we will get going. Okay, we're going to go ahead and just jump right in. Just as an FYI, this is being recorded, so if you miss anything, we will have a recording out to attendees afterwards. So thank you so much for joining us. My name is Madison Hammond. I am a senior policy analyst with the Illinois ACEs Response Collaborative. And today we are featuring our trauma-informed hospital working group and the lessons that some of our members have learned both through collaboration with our group and as well within their own hospitals. So thank you again to all of you for joining us. Just some quick technical details before I pass it over to our moderator for the day. After the webinar, you're going to receive a couple of things from us. I already mentioned the recording. You'll also receive a short evaluation survey, ways to participate with the collaborative. So if you are a hospital that is interested in this, we encourage you to reach out. You'll also receive links to our website and to some of the materials that you hear about today. And like I mentioned, a recording of this presentation. Throughout the webinar, I am going to be moderating and looking at our questions box. So you'll see there on the side of the screen, there is a place to ask questions. We will be passing those along to the panel at the end of the webinar. So please, as things come up for you, please feel free to type those in and we'll make sure that they get there. We also will have we'll also be passing out people's contact information. So if you want to reach out to folks afterwards, please feel free to do so. So just very quickly about who we are, the collaborative is housed at Health and Medicine Policy Research Group, which is exactly as the name suggests, a policy, research, and advocacy group located in Chicago that is focused on improving health in Illinois by promoting health equity. And the collaborative itself is one of the projects that does that. And we do that through this cross-sector movement to prevent trauma and promote thriving across the lifespan. And that is done through 3 buckets, through our capacity building. So that includes webinars like this, trainings, materials that help support communities and organizations that are working on trauma-informed principles, policy and advocacy, and research translation and dissemination. So how do we get this information out to different groups of people? And part of that is our hospital collaborative, hospital working group that you're going to hear more about today. It falls under actually all 3 of these buckets and the work that our members do. So very quickly, our panelists for today, they're going to have a chance to introduce themselves more thoroughly. But we are joined by 2 of our largest hospitals here in Chicago, and we're very excited. So we're joined by Hannah Kite, Andrew Wheeler, and Erica Williams from Cook County Health and Hospitals. And we are joined by Tracy Kurtzer, Holly Manfrizo, and Judy Pasternak from Northwestern Medicine. And they are located in Chicago and in one of our neighboring communities of McHenry County. So we're very excited to have them. And very excited to have our moderator today, Marlita White, who comes to us from the Chicago Department of Public Health and specifically the Office of Behavioral Health and Violence Prevention. Marlita is a longtime partner and leader here in the collaborative and a longtime leader in the hospital working group. So we're very excited to have her be our moderator and to introduce the hospital working group to you all. So I am going to pass it over to you, Marlita, now, and share your screen with folks, make you the presenter. And as always, in this time, we thank everyone for their patience as we work through all of our technical things. So Marlita, you are now the organizer and you are free to take the reins. Oh, Marlita, we actually can't hear you. Can you take yourself off mute for us? There you go. You're unmuted now. Oh.
Okay, great.
There you go. Thanks, Lynn.
So thank you, Madison. I think what I'll do just to minimize opportunities for challenges, if Madison, if you want to just maintain the advancing the slides.
Sure thing, I gotcha.
Great. Alrighty, so welcome everyone. And what I'm going to do is really try to give you a sense of the collaborative and the work that has been a part of this far-reaching initiative for at least now 3 years. The Trauma-Informed Working Group was created as a collaboration between the Illinois ACE Response Collaborative and the Chicago Department of Public Health as a part of a response to the call that the health department issued to area hospitals to work more closely together. We currently have about 19 member hospitals from across the Chicagoland area, all of whom are working to implement trauma-informed policies in their various organizations. Some of those members are represented on this slide. Yes?
Marlene, I'm sorry, I'm gonna pause you for just a second. It sounds like we're having some tech issues. So I'm gonna just ask for a quick pause from folks. Sorry about that, everyone. Just a second. Marlene, if you want to keep on talking, and I'll go ahead and just get our visuals going, but our audio is great, so go ahead.
Okay, great. So as we talked about, as I mentioned already, that some of those member hospitals are represented in the logos you see here on the slide. We started this group in 2017 because there was this interest from behavioral health leaders from the hospitals themselves in creating a learning and collaborative space for member hospitals to really come together. These hospitals range in size and location, with some of the hospital systems having sites that are located across the state of Illinois. They include also community and safety net hospitals, as well as some large academic medical centers. So we have a varied group of partners. It is the only group that we know of its kind in the nation that is really working to unite hospitals and healthcare systems around the notion of bringing trauma-informed transformation to scale. So if you know of other efforts that are similar, we'd love to hear about that. The working group itself has provided, we think, an unprecedented opportunity for systems to really think about how to work together where there's normally this kind of a sense of competition, but instead to work together to share resources, to think through challenges, and to learn from national best practices in order to implement systems change. It has really been a great opportunity for the collaborative to learn from our members' methods and to respond to their needs, learning opportunities, trainings, and technical support. We can go to the next slide. In doing some of the interviews with member hospitals under what was an environmental scan, we really began to understand and uncover some motivations that the hospitals were able to talk about. So some of those motivations included the release of the Healthy Chicago 2.0 policy agenda, which was released in 2016. And in that document and that body of work, it really was this message to bring attention to trauma and healing across the city, but it's certainly including hospitals. And there was within this citywide plan, really called for Chicago to become a trauma-informed city. Many of the hospitals who participated in the environmental scan felt that they lacked comprehensive strategies to become trauma-informed as an organization. And then in some cases, there was really no strategy at all. And since they felt like their organization leadership also in some instances needed to understand trauma and the call to become trauma-informed, they needed more assistance to really build out talking points and internal efforts around those trauma-informed principles and trauma-informed needs and how to elevate that to the level of leadership's attention. Also in the environmental scan, we heard back that some partners or hospitals felt that they believe that their hospital could not effectively address health inequities without incorporating a trauma-informed framework and trauma-informed practices. So there was this sense that there needed to be lead work put in place so that they can even address some of the other work that the hospitals were already engaged in. And then lastly, some were motivated by the needs of really specific populations within their overall patient group, um, where the hospital may be focusing on their population, but there needed to be a trauma-informed lens applied. So you think about serving communities of color, serving refugees, or serving victims of sex trafficking. Many of the respondents felt like they really needed support and a framework to provide the best care. We can go to the next slide. At the same time, the environmental scan identified some challenges from those hospital respondents. So few of the resources that were really dedicated in terms of like time and funding across any of the healthcare systems were really leaning toward trauma-informed transformation. And we know that the need is greater even now, given that we are in the midst of a COVID pandemic. Those resources, time, and funding are stretched even more thinly. Many of the healthcare systems have gone through mergers, which always change dramatically the landscape, and that has happened for some of the partner organizations over the last 3 years. We've had several member organizations go through mergers, and some have even gone through it more than once, since this group has really been operating since 2017. In terms of competing priorities, those range really from clinical, how to address clinical needs in a different and better way, financial and even community-facing demands. And so the challenge is to how to focus on trauma-informed when those other demands are really heightened and demanding the same attention, if not more. Again, this is something certainly that COVID helps us to appreciate, the COVID pandemic. And then lastly, frontline staff have raised concerns about the initiative coming on board and what would be required and whether or not that would pose this sense of initiative fatigue. So there's a concern that will trauma-informed be just another fad that people will put a lot of time and effort into when nothing will ultimately come of it. Next slide. But nevertheless, the group has really been moving forward. And in the years since we've started, we believe there's been some significant progress made. And so, for example, there's been presentations offered to not just member organizations, but even opened up to others to participate in webinars and to be able to hear back from kind of best practice teams from St. A's, the Milwaukee Children's Hospital in Milwaukee, the Ballard Health team that's serving East Tennessee and Southern Virginia, and the Montefiore team in New York. This group has launched web-based toolkits and guides that really help to create, provide information and help organizers of teams in the various hospitals. So how do you launch and maintain internal trauma-informed working teams at your hospitals? They have been able to, within this group, to align across really a shared baseline of staff assessment tools. So some of the work that we were able to initiate in CDPH, but to really see how the partner hospitals would modify those tools and really focus those tools on use within their own hospitals. There's been presentations made over these 3 years to senior leadership at several hospitals, and as well as affiliated community partner organizations. 10 of the hospitals have trauma-informed working groups, which we're very excited about. 10 hospitals have initiated trauma 101 training at varying scales. where we even have one hospital that has a full-scale project really to address all the staff, and that is in collaboration with the Illinois ACE Response Collaborative. So that's very exciting work. And then also we've been able to train hospital-identified community partners in adverse childhood experiences and trauma-informed care and various other titles. So when we think about the working group, and I believe I mentioned that there was a toolkit that was launched and made available for hospitals. Let's talk a little bit about that toolkit. So we've been able to provide resources for members that include this resource guide that you see on the slide that really is designed to help an organization start and sustain an internal working group at their individual hospital. This guide is designed to provide members and the organization, the hospital as an organization, with accessible tools and strategies to establish and grow a work group at their healthcare organization. It includes resources on adverse childhood experiences, the research study itself, resources on trauma, and resources on trauma-informed care that can be shared with members within the organization as well as throughout the organization itself. So how do you create a working group? How do you resource the working group? And then how do you resource the entire hospital as an organization? This guide is meant to assist in leading a work group that advocates and implements the trauma-informed cultural transformation, and then practices that create safer, more supportive, and healing-centered environments at hospitals and healthcare organizations. So we are, again, we can go to the next slide. So now, as we've talked about what the work that has gone on as the working group for the 3 years, when we think about what's next, how do we move forward? Trauma-informed healing and this kind of work around being trauma-informed centered is really so much more relevant than it even felt a year ago. But that's not without significant challenges. We know that funding, particularly now, is uncertain. Although many hospitals and organizations are beginning to see how essential this work is as they turn their attention now to meet the national call for anti-racist work, to really begin to do work that's holistic and focusing on brain and body support of staff and patients. But nevertheless, to that end, the working group is collaborating with members to create short internal marketing materials to help members make the case to their leadership about why this work is needed and why it's needed so much right now. We also, and will continue to do so, provide trainings and technical support to individual members and their staff. Some of you will hear more about some of that work you'll hear more about today with some of the speakers that will follow me. But we hope that we're really encouraging members across these initiatives to continue learning, to continue connecting with their partners as they deal with COVID-19, as they really work to elevate and meet the challenges of racial justice and the rising challenge of burnout amongst staff. It is our aim that hospitals across Chicago and ultimately across the state of Illinois will continue to work together and work toward trauma-informed healing-centered transformation within their own organizations, to make sure that we're providing better care to the communities that are within our organizations, as well as those communities that surround the organizations. Keeping our partner organizations, meaning the hospital partners, at the center of this work. So I'm very excited now to turn the conversation so that you can begin to hear more from some of those participating organizations. And we'll first go to the Cook County Health team, and they will introduce themselves. So welcome to the Cook County Health team.
Hi, everybody. My name is Hannah Kite. I'm a regional health officer at the Cook County Department of Public Health and a co-chair of the Cook County Health Trauma Informed Task Force. With me today are Erica Williams and Andy Wheeler. Erica is a psychiatric social worker at the CCH Robbins Clinic, and Andy is a clinical social worker at the trauma unit at Stroger Hospital. Erica and Andy lead our training committee, and they're going to be talking about the incredible work that they've been doing in the last year, despite all the challenges of COVID. I'm going to, Madison, if you can go to the next slide. Thanks, Andy. So I'm just going to give a really brief history of the Cook County Health Trauma Informed Task Force. The formation of the task force was identified as a goal in the Cook County Health Strategic Plan for 2020, and the health department was asked to identify some best practices and convene the group. We also did some stakeholder interviews to inform the in-person meetings that we had. So starting in February of 2019, we had 4 in-person meetings. And as a result of those meetings, we created an internal report with recommendations to implement a trauma-informed approach at Cook County Health. In those in-person meetings, we tried to include as much diversity in sort of professional affiliation and in workplace location as we could. So we had social workers, nurses, physicians, public health practitioners, psychologists, and administrators as part of those discussions. For instance, another one of our co-chairs leads the patient relations group at Stroger Hospital. And next slide, please. So these are just these are the key recommendations that came out of those discussions. They include being a leader in and communicating effectively about trauma-informed care. Also having, we identified the alignment between the system's goals around providing high quality and safe patient care and how that's connected to trauma-informed care. A third key piece was promoting wellness, collaboration, and empowerment among the Cook County Health workforce. The fourth key piece, which Andy and Eric are going to talk more about today, is to train all Cook County Health at all levels on trauma-informed approaches. And then finally, to provide safe and private clinical spaces for families and staff. And then next slide, please. So as an outcome of those in-person meetings and the internal report, we've seen some sort of movement forward in the last year. Our ACHN, our ambulatory care network leadership, really found the trauma-informed approach helpful for some of the leadership work that they were doing with their management and their staff, and have sort of weaved that into a lot of the work that they've been doing in the last year. Andy and Erica presented at one of their leadership trainings in February of 2020, which right now kind of seems like ancient history or maybe 5 or 10 years ago, but it really sort of created a lot of momentum within ACHN. So the much larger group is sort of on pause because of all the demands of COVID, but the training committee has been incredibly active. And we've also created a series of flyers around self-care. Those flyers are on our website and that it's been translated into different languages. And so if you'd like to see some more information, please check that out. So I'm going to turn it over to Andy and Erica to talk more about the work that they've been doing.
Okay, so I'm going to begin in talking about some of the accomplishments of our training committee. Madison, if you could do the slides for me, thank you. So some of our accomplishments, as Hannah was just stating, she was talking about the ACHN leadership retreat that was in February. That I think I can speak for our committee. That was a huge accomplishment or milestone for us. We were able to present to leadership and kind of have them to hear, you know, about what we've been talking about and planning about, this thing called trauma-informed care. And they seem to take it really well and enjoy and want to hear more about it, which then we went back and talked more, brainstorming about it. And we did not realize that a pandemic was going to hit shortly thereafter. And it took us into doing the virtual lounge trauma-informed care trainings. And in that, it was virtual trainings to support our staff during COVID-19. We had about 5 virtual trainings, and each training we had maybe about 15 to 20 participants at each one of the trainings. And we want to give a special thanks to some of the parties who assisted us with doing the trainings, which included the Resilience, the Center of Abused Women and Children, Healing Hurt People in Chicago, which assisted us with some of the trainings and presented on violence during the pandemic, as well as we had topics dealing with self-care and stress and resilience, which was really helpful for our staff during this time. We as well presented during a leadership all staff meeting to just talk to some management about taking care of themselves during the pandemic. And oftentimes they're busy taking care of their staff, but not always thinking about themselves. So that was really nice talking to them about. And as Hannah spoke earlier, we then developed the flyers and the infographics to be available for staff on the intranet and having 5 language. Because one thing that was discussed and talked about, a lot of people talked about they wanted something to take away from these trainings, but having something physical. So we came up with these flyers, whereas they can pull those up and reference back to them, and they're in 5 different languages. We're proud of the partnerships that we have with Health and Medicine Policy Research Group, and as well as CCH Racial and Health Equity Initiative. Then we began a pilot to do trauma-informed care as the trainings that we were talking about, whereas it was small focus groups comprised of social workers, patient care advocates, trauma surgeons, hospital police, and in both the main hospital and some of the outpatient clinics. And to date, we have trained over about 119 staff and in about 6 different trainings. We were targeting first, as you can see, like the trauma surgeons and hospital police and some of the clinics that had maybe a high rate of like violence, gun violence, that type of thing, to get a lot of feedback and in hopes to get more staff who in turn wants to be trained as well. Then beginning of this year, we began the part 2 of our trauma-informed training, whereas dealing with the historical, the structural, and the trauma, as well as staff burnout, where we talked a little bit more deep about the historical aspects of trauma and how it impacts us on a daily basis. And I'll turn it over to Andy to talk a little bit more about the work that we've been doing.
Cool. Thank you, Erica and Hannah. So we did want to address some challenges that we've had. I think we feel pretty proud that we've been able to keep this rolling, especially through the pandemic, but we definitely have had some challenges that we thought we'd talk through for folks that might be interested in this type of work. And they kind of fit in these 4 different categories: development, getting things started, navigating our own internal system, dealing with COVID, and then sustainability. So the first part, just like getting started, was very difficult. Setting meeting times, finding out when people could meet, getting acquainted with one another, trying to define our mission. And this part here, I'm talking specifically about our training committee. So there's the overall task force, and then we split into a subcommittee. So this is the training subcommittee. And so it was just kind of getting things rolling was a little difficult. And a lot of this is because this is nobody's primary job. So this is all volunteer hours, and I'm sure like everyone else, everyone is very busy. So sometimes, you know, you have a meeting, we have action plans, but no one really has time to get things done between meetings. And a lot of those initial meetings were really talking about like, who are we going to offer the training to? Should we adapt it for different groups? We spent a long time developing our own trainings that we thought might be specific to county. Then we thought it'd be easier to have an existing training, but then we had all these back and forths over how that would work here, things like that. And while we were developing our own training, we kind of realized, particularly a lot of us in the group are clinicians and we know a lot about trauma. However, just because we're good at treating trauma doesn't mean we're necessarily good at making trainings. And so it was really helpful at that time to make sure we relied on some of the multidisciplinary team that wasn't really initially brought into the overall task force. So we had some folks from our HR department come in and help us to talk about how to enroll things or how to navigate the county system. And then it was really great this past fall of 2020, we developed a partnership with Health and Medicine Policy Research Group. And we were like, can you guys please help us with the training? And then the next thing is sort of dealing with logistics and stuff, which is, I think the biggest one is time. And when you're doing a training, I think a lot of the biggest issues have to do with time. Who has the time to go to a training? How do we stay organized and work through all of the logistics since the task force is made up of volunteers? It's been really hard to find time for staff to attend trainings. So in particular, a lot of our more frontline staff workers like nurses are on pretty strict shifts. They're very busy. So it's very hard to find a time. If we want to offer something, if it's during work hours, it's hard for people to take time off of work. And if it's not at work hours, people really don't want to do this when they're not working. They want to be resting. And so given the amount of other trainings that we have to do in a year, it's been a little difficult to find time. And we've gone back and forth. Everything is voluntary as we've been piloting it with these specified populations. But as we move forward and we want to offer it to everybody, it'll probably stay voluntary for a period of time. So we had this sort of discussion, should it be a mandatory training or not? And what does that mean? There's also lots of just internal processes, and I encourage anybody to just get familiar with their own internal networks. So there's a lot of logistics in a big healthcare system. So one little thing that happened here, for example, is we have an internal online system called LMS. It's our learning management system. It's where we do our annual trainings. It's great. We were like, we can offer our training through the same system. That way everything is categorized there. We can track who's attended and things like that. And we were like, this is great. And then our first couple of trainings, we didn't realize that the invitations we sent to people, they could not sign up for the training because in our system, they needed an approval from their manager before they can attend it. And that notice doesn't come up until they, click to join the meeting at the time of the training. So lots of little things come up while you're doing this sort of stuff. Then obviously COVID has changed a lot of our plans. We initially were going to do in-person trainings, and actually the shift to virtual trainings I think has probably helped because we don't need to find the space, but it was definitely a challenge in the beginning. And then it changed the types of training that we offered. So, at first our task force members, we became busy with COVID, especially our partners from the health department. So that made it so that our overall task force, it was hard for us to kind of get everyone together because a lot of the folks leading this, like Hannah, are from the health department and are obviously busy with other things. And then other things that COVID has come up with are like, for example, we wanted to offer training to our medical intensive care unit staff because we feel like they've been through quite a big trauma, but the feedback we've gotten is like, it's just not time, we need to wait till a little bit later because they're kind of like in survival mode. And then just anything else related to COVID, just everything has gotten more difficult. And then finally, we are trying to make sure we have sustainability and we keep the momentum going. Sometimes keeping momentum is a little hard, especially kind of in the summer when COVID was just like ravaging everything. We were really having a hard time just keeping our meetings and keeping everything going. We also need to re-engage our leadership to some extent. We just got a new CEO that we need to re-engage, and there's been some shakeups in leadership here. So we need to kind of bring a lot of these recommendations back to leadership and make sure that this is still made a priority. And we also need to look at whether or not we need financial resources and how that could help us. Everything right now is done in kind and, like I said, on a volunteer basis. So where are we going to go from here? I think the big thing is we obviously need to get back on track with our overall task force objectives. And a lot of this is just rebounding after COVID. So not having the full task force meeting has made it so some of the other projects that we want to work on, in addition to training, get brought up again. So for example, like we wanted to have more trauma-informed spaces. That just hasn't been able to happen right now because of COVID. The next thing is we want to get trained as trainers ourselves. So we are, utilizing health and medicine policy research group to help with our trainings, but hopefully we can get trained as trainers at some point so we can have a little group here that can do the trainings. The next step is really we need to expand our trainings to more staff and diverse groups within our health system. So like we said, we piloted with the very focused groups, but our goal is to train all staff in trauma-informed care. And so we need to expand to other workers, managers, and as many departments as possible, our environmental services, our clerks, our nurses, our CNAs, et cetera. And we need to make decisions about, this, like I said, making the training mandatory or not, and how that'll affect us moving forward. We also want to enhance our web presence. We have a website, but we want to include more resources on there. And we want to make sure that we that people know about our task force. This is a very large health system, and lots of times there are working groups that people don't always know exist. And so we need to make sure that people are aware that we exist, because we actually had a training where someone from our family medicine department reached out to us because they heard about us, and we did a great training for them. So we need to make sure that keeps going. And that also helps with the point before of expanding our partnerships. So we have some internal partnerships, and we also need to make sure that if there's partnerships outside of our system, that people know how to find us. Like I said, we need to look for funding opportunities when those are available. We do need to re-engage our leadership. We've had pretty decent buy-in from leadership, particularly from administrators. We do have administrators as co-sponsors, and in our clinic sites, doing trainings for leadership, I think really helped with that buy-in. And then finally, we want to look into, evaluating our trainings and investigating any research opportunities, because, I believe that there's evidence that these are helpful, but at least at our hospital, we want to see, how much has this actually changed behavior? How much has actually improved patient care? And that's something that we'll want to look into in the future as well. And I think that wraps up our section. So I'm gonna, stop sharing my screen.
Hi. So, Madison, I'm going to ask if you can see the screen. So I'm not sure.
Yep.
Cannot?
We can. We can see the PowerPoint presentation.
Wonderful. Okay. Yep. So, sorry for my delay. My name is Holly. I'm from Northwestern. And thank you so much again for having us here today. We are excited to share our progress toward creating a trauma-informed healthcare system as well. And I would like to start with introductions from the Northwestern team. So I'm not sure if, Tracy, if you want to unmute for a second just to introduce yourself.
Yeah, will do. I'm Tracy Kurtzer. I'm the Medical Director of Trauma-Informed Care and Education in the Department of Obstetrics and Gynecology at Northwestern, and I'm in the Central Region.
Wonderful. And Judy?
I'm Judy Pasternak. I'm a professional development specialist in our Northwest region with a specialty in behavioral health and substance use.
Thank you. And then as I mentioned, I'm Holly Manprizio. I'm a program director for community health alignment here at Northwestern. So as we heard from the Health and Medicine Policy Research Group team in Cook County, there's an abundant amount of evidence that trauma and adverse childhood experiences can result in poor adult health outcomes, and that a trauma-informed approach could positively impact patient outcomes and experience, as well as provider and staff well-being. But in addition to the fact that this work is scientifically grounded, I felt that it was important to mention that the work that we're going to talk about today directly ties with Northwestern Medicine's Patients First mission and our longstanding commitment to the community. So this mission acknowledges that it is our responsibility to improve the health of the communities that we serve. And so probably what I appreciate most about our commitment to trauma-informed care is a phrase that I hear a lot from my leadership, which is that this is the right thing to do. And so with that mission alignment, it was no surprise when we learned that this work had been underway at various levels across our system for quite some time. And as Tracy and Judy and I, we came into this work through various channels and different experiences. For myself, my perception in the community department, learning about trauma-informed care as a strategy to address violence, trauma, and behavioral health needs that emerged from our community health needs assessment. And from Tracy and Judy's understanding of trauma-informed care through their clinical work and seeing patients who have experienced trauma such as domestic violence or sexual violence, human trafficking survivors. So basically this team has had a long history of utilizing a patient-centered approach with trauma-informed principles. But it was actually through our participation in the Health and Medicine Policy Research Group that we were able to come together internally, formalize a process and operationalize this work. So we are quite a large system, and so finding each other and coming together, we do want to credit the Health and Medicine Policy Research Group for aligning us in that way and providing the background for knowledge sharing and helping us to identify those three main areas of focus that you see on the screen with organizational and leadership, clinical patient care, and staff and employee well-being and wellness. Those are the three areas of focus that we launched into and developed strategies around. And so now we're working to align and expand our trauma-informed care approach. And before we get into those phases, I'm going to just show the progression of this process to date. So we established 4 different stages, and Tracy and Judy are going to walk us through those phases during our time today. But there's a couple items that I just want to note before we really dig in, which is that the first being this process has been concurrent, really happening on multiple levels at the same time. We've been doing the work, we've been developing the process and conducting trainings with our staff as we're building those operations, which has led to some crossover between the stages and this really type of organic evolution with this process. And then secondly, I want to note that engaging leadership has cut across all of the stages of this work. So this type of communication and constant connection with our leadership has been a really necessary component that we want to highlight. And I do want to give credit that we have been very lucky. Our leadership was very interested to learn more about trauma-informed care and really allowed us the time to allocate what we needed to, time and resources, to this initiative and push the process forward. And they also supported connections to the various strategies in the system as ways to transform and move this along faster. So engaging additional leaders, engaging the right departments at the right time allowed us to have make the progress that we've had up to this point and impact at that system level. So I'm going to hand the floor over now to Tracy to walk us through and start talking in or diving into some of the details on our approach.
Thank you. I hope everybody can hear me okay. So phase 1 really kind of came together in 2019 as Holly mentioned. Kind of the hospital collaborative really brought the people that wanted to focus on this work together. So it started with myself and Holly coming from the central region, and then we were joined by Jen Boletto and Judy in 2020, who represent our Northwest region. The collaborative really set the stage for us with initial education and peer support, kind of helping with a framework to advance our mission. But our NM work group really kind of, which started really in 2019, more with self-education and some individual and shared work across the system. But really, it kind of came together when we had our additional champions join us in 2020, and then we were really able to develop a more coordinated process. We wanted to, determine best practices, fill some of the gaps we had identified, and then continue to engage and find more champions and leader supporters for the work we were trying to do. So our work group now has expanded even further into the West region and really a multidisciplinary team. So we're super happy about that. And as Holly mentioned, all of our individual supervisors and leadership were very supportive for the concept, working on this and coming back and presenting what we were learning and strategies that we were looking at to try to incorporate this. And really what I was kind of terming when I would talk to them kind of a trauma-informed care transformation for our entire system eventually, but how do we, start the groundwork for that? So next slide, thank you. So again, that was kind of stage one. Now, again, as Holly mentioned, there's a lot of overlap with these, but for stage two, you can go to the next slide. Once we really became a more unified group, we did some more of our own group education because we all had kind of self-educated ourselves, but we reviewed models, we reviewed outcomes data, and we defined our approach to infusing these principles. And also to determine, we needed kind of to answer that so what. So when we were presenting this to people who were maybe a little less informed about trauma-informed care and maybe looking at the bottom line for our institution, what does this really mean? And basically recognizing trauma as an important factor impacting, patients' health through the lifespan, and that having Northwestern medicine focused that on a trauma-informed approach would likely improve patient outcomes, decrease costs, and improve staff wellness. So we really wanted to enhance upon Northwestern's mission, again, a safe, caring, inclusive environment for both our patients and staff. We created communication materials. There's an example of one of the kind of one-pagers we created to help present the information succinctly to the point. And we also decided that we wanted to do a current state analysis. And the goal of our current state analysis was basically to gain a better understanding of all the trauma-informed care practices that were happening kind of across our system. So people might not recognize the work they were doing as quote-unquote trauma-informed, yet how were they doing things that were enhancing patient care, that were enhancing employee wellness? And with this increased awareness of all these actions happening across the system, we really hope to better align the work that was being done, to identify some additional gaps, increase partnerships, increase our work group, and certainly give support where we could to these efforts. So we really identified right away 3 areas to kind of link into as well, into some of the strategic plans that were going on in our system in regards to community health, quality, equity, and staff wellness. And so we individually and with some overlap linked into these committees and started promoting trauma-informed care in the work that was already being done in these realms. So next slide. So again, these are kind of the 3 initial in phase 2 areas that we started integrating with, and again, a little overlap, phase 2 kind of leading into phase 3 this year, but basically through 2020. So we became part of the Community Health Initiative, and that was in response to the goal of violence reduction as identified in the as a priority health need from their Community Health Needs Assessment. We became part of the Quality Equity Committee and integrating trauma-informed care and some of the initiatives and work that they were starting to engage in. In particular, one example that's really taken off is the social determinants of health screening that's being piloted across our system. And integrating trauma-informed care practices in that work. And part of employee health and wellness, particularly with the employee reactivation team after the COVID crisis, when many of the staff were working remotely and a lot of systems shut down for a while, and then staff were coming back. How do we support the staff, and how do we support the staff that were already working here as frontline workers, exposed to tremendous amounts of stress and trauma in their own right. So next slide. So this is basically, our work group had really solidified. We'd started engaging in these different areas, and then the COVID-19 pandemic hit, and shortly after that, the racial justice protests intensified after the murders of George Floyd and Breonna Taylor. And the pandemic, I think, as Cook County also alluded to, really highlighted the need for this work in the context of health equity too, something we always knew about and spoke about, but I think the awareness really picked up across our institutions. The really atrocious levels of disparity and the mortality from COVID that was felt to be due to chronic health inequities, was felt in communities in Chicago, but also across the United States, and that was known to be due to, chronic disinvestment, systemic racism. And then the protests also really, I think, also helped bring to light to a lot who maybe really weren't completely aware of the level of trauma is how these communities of color and marginalized communities, the depth of the trauma they were dealing with, on top of the racism and unequal system of criminal justice that they were facing. So with this increased awareness of the impact of trauma on individuals and communities, the importance of our efforts, I think, became more recognized in our system and in the hospital, and also in our outreach to the community. So our work group really used this opportunity of what I call enlightenment, the period of enlightenment, to push our work forward in these groups that we were already working in, and to engage and open up to other groups to reach out to us. So just continuing to do more advanced work in each of those realms. So I'm going to turn it over to Judy now to take it over as to where we are kind of at now.
So once again, this slide, just very briefly, just want to reemphasize where Holly started, and to talk about that, though this looks linear, it definitely is a concurrent process, and it's organic. And truly, the opportunity we've had is to really start to weave this within the culture in so many different ways. So we're weaving it in and informing and educating as we go along. So though it looks kind of in a straight line, it isn't. So in terms of implementation at phase 3, which is kind of where we are at this point, we want a safe environment for our employees and our physicians. We had a wellness reactivation plan that took place as a result of COVID. So we started bringing many of these pieces and strategies for wellness into our everyday employee culture, our training, accessibility to wellness information, and encouragement to engage in self-care as employees, no matter what level of employee you are, no matter who you are. We started quite a few staff trainings directly related to trauma-informed care and ACEs. Jen Belletto and I had an opportunity to train all our clinical and non-clinical behavioral health staff in ACEs and trauma-informed care over the last year. And we also, I do want to give some credit also to the McHenry County Mental Health Board, who provided this ACEs training to us and helped us connect with this larger group. And also we are doing community training. So they've been everything from Mental Health Board offers a training that both clinicians and consumers can attend from behavioral health. We've had participation in the Chicago Resiliency Network. And we have even done presentations for our local chambers of commerce on how to recognize the trauma of employers and employees, and help those employers help their staff as they go through this period of time. And like we've said, it's an ongoing moment to engage leadership. So it's always been like, we're doing this, we have autonomy, and leadership come on in and see what we're doing. And we've had engagement and autonomy from the start, and we just keep working forward. And we can go to the next slide. So phase 4, we want to see more and more of this woven culture, this trauma-informed woven culture. And so we're looking at how to integrate more and more trauma-informed care into our policy and practices. For instance, I know Tracy is working on an abuse screening assessment and intervention policy, something that will definitely have a large nod to trauma and past trauma. Current state analysis that we've been working on, as they mentioned, there was a survey and we've looked at what are people doing. And again, I want to also emphasize something Holly said earlier about many people were doing trauma-informed care and not even knowing they were doing trauma-informed care. But they knew it was the right thing, and they knew they were supporting people and helping them through their wellness. So to just bring that into a more formalized clarity, I think, to create policies and education and trainings around really understanding what this is and what it's been from the start, which is trauma-informed. And again, constantly engaging leadership in future states and recommendations and support. So what are our next steps? So our work group would love to see a formal strategic plan, which is always in the works, right? A training plan to develop a trauma-informed workforce. So how do you do that? As of today, for instance, in our region, we are doing, it's part of our onboarding today when we talk about safety and violence and past experiences and patient satisfaction. We are talking right away about ACEs. We're talking right away about past trauma, the things people bring to the table, not having one-size-fits-all approaches to anything. So we're creating that cultural mentality of trauma-informed care, I think, from day one in our onboarding, as an example. And we're would like to see this committee become a committee, you know, not just our work group, but something that's more of a quality equity subcommittee. We are also looking at how can we inform expansion and site design to make sure that our future areas, wherever we expand, will have a trauma-informed focus on the space as well as the clinicians and the accessibility to the people who are in the region, wherever it is you expand. And finally, to continue to measure for outcomes, to continue to support evidence. We're an evidence-based, we're healthcare. It wasn't just the literature search that told us we were on the right track. As you said, it was the right thing to do, and to look at the future outcomes to continue to move forward through that process and ensure that that stays a piece of our culture, and continue to look at staff well-being. Holly, Tracy, is there anything you would add before we close?
Oh, I think that yeah, that definitely sums it up, Tracy. We can hand it back over to Madison.
I think we got it covered.
And we,
Hi,
I think
everyone.
that last slide, we put our contact information, so all of you should feel free to contact any of us anytime at Northwestern Medicine for any more conversation around this. We're happy to connect with you anytime.
Great, thank you so much. Let's do a sound check to see if everyone can hear me.
Sound great, Marlita.
Great, excellent. I want to, before we move to a short period of discussion, want to really thank both the Northwestern and Cook County teams to really come and talk about so much work in such a short amount of time. And you all did it with a level of kind of ease that probably dramatically underestimates really how much work and the level of commitment and probably even chaos that is involved in trying to negotiate this huge lift. So thank you all so much. We know that we had a little bit of a slow start, and so we want to find out if our audience can, if people have questions. We've asked if some of the presenters would be able to stay on for about 10 minutes just to take some questions. And so we invite you all to go ahead and use the chat if you have questions. This will also allow us to redirect any answers to you that get missed just simply because of time. So we're going to go ahead and take a look at the chat and see if there are any questions.
Marlita, I flagged the ones that are coming in for you. So You see, I know we had one from Desiree about DEI work.
So one of the questions I believe had to do with really trying to understand which of the partners are involved in working in around issues of diversity and inclusion. And when we think about between either the Northwestern and county teams, have either of you done any specific work in those areas that you can mention? If not, we can also look back to the other partners across the collaborative and respond back after the webinar.
Yeah, we actually also linked into the Diversity and Inclusion Committee. I attended one of their trainings. I think it was for the Human Resources Department, but also integrating some of the trauma-informed care pieces into the work they were training the workforce in, as far as our human resources, as far as recruitment and dealing with staff issues and things along that line.
And so Tracy, the group that you're mentioning, this is a group that was already underway at Northwestern doing kind of work, self-directed work. And so you were able to connect the trauma-informed teams initiative to that. Was that an easy process of blending? Was that a negotiated kind of coming together? Can you say
I think it was
about how that went?
Yeah, I think they were very open, which would, of course, be understandable for the leaders in that committee and we're already, I would say, quite honestly, their training was already a very trauma-informed training for the staff that they were working with. But yeah, there was pretty much buy-in and support for the work. In fact, we'd even talked about, in some ways, maybe integrating trainings in a unified way for our staff, and that hasn't materialized, but there was definitely an openness to it. I think the challenge always, which was brought up earlier in this talk, was, it's time, and is it just another, from an administrative level too, is it maybe just another thing we're putting our workforce through that's just, more time and more time for them for trainings, and does it start to become burdensome, and wanting to avoid that. So it hasn't fully materialized in that way. And so it ended up that we started just working on our own trainings and getting them out on our own. But there definitely was very openness and awareness of integrating that information shared with the work that they were doing.
Okay, so maybe if people have additional questions, we might try to flag those and see if there's some guidance that you might provide. Is there anyone from the Cook County team that wants to talk about whether or not you were able to have a touch point with the diversity and inclusion and racial justice work and how that worked on your end?
Yeah, we've had some, but not a ton. This past summer, the health system had developed a racial and health equity initiative, which was sort of in response to the murder of George Floyd, and they started some of their work, I guess, in the fall, and we overlap to some degree, and it's part of so that initiative. Some of the people that participate in that are also part of our trauma-informed task force, and so there's a pretty big overlap, but we are kind of two independent working groups. So I think it's kind of one thing I touched upon is sometimes within your own system you have different people doing different things, and it's important to know what each other are doing. And so like some of the folks from that group, the people in charge of that group have come to our trainings, and some people in our task force go to those meetings a little bit more. It's another time thing, for example, like their standing meeting, I'm not able to attend that personally. I think sometimes that has an issue. You just have a lot of people, it's hard to be fully involved. But yeah, and I don't know, Erica, if you have any more to share.
I think that might be enough of a little of a teaser to at least help the audience appreciate that there are these synergies that existed, and that your efforts on the trauma-informed side, whether you were solely over there or you already had some investments in the diversity and inclusion and racial justice space, but there wasn't a lot of resistance to bringing those two conversations together, and that there seems to be in both locations interest in even taking that braiding of these initiatives further. I want to see if we can move to another question. It sounded like there's a question, it seems like Beth had a question around leadership engagement, which is always an issue. It comes up all the time across the collaborative. Can you all, maybe from each hospital system, just talk about one particular engagement initiative or effort that you think was really profitable? And then also, if there's any other space where you've talked about in your materials, other ideas that people can use to engage leadership. I know also the collaborative itself has materials to share, but can you all talk maybe just one example where you really had a really strong response to engage in leadership? Can we start with Cook County?
Sure, I can talk about it. The first time we kind of presented the trauma-informed care at the leadership retreat, we got a lot of great feedback from leadership. They were engaged. They asked a lot of questions about it. They requested more information, more trainings. They wanted more staff to be trained on the topic as well. So we get a great response, and I think that's what helped us to kind of spearhead and go further with a lot of other work that we have been doing and a lot of the accomplishments that we kind of talked about today, because they were kind of behind us and they understood the great need for it and seeing how trauma affects the patients that we have and how much it's needed, especially right now. So it's been great. And even preparing for it, as Andy talked about and others talked about, that we had some leadership that was involved in our committee. So we kind of had a little bit of them kind of engaged from the beginning, and they kind of helped us to kind of push forward, and they're still pushing forward and helping us. And that makes it a lot easier to get things done.
Okay. So you really snuck in two different ways that you all have been able to engage your leadership, kind of bringing them into the planning process as a team member, as a vested partner with sweat equity, but then also creating an opportunity for them to hear from you all really as a set aside time and focus on your conversation.
Yes.
Anyone else? How about on the Northwestern side? Did you want to say anything about a particular effort to engage?
Sorry about that. Yeah, so engaging leadership, I think there's a couple good examples. Within the community health side, one of the major projects at the hospital right now is addressing social determinants of health and incorporating social determinant of health screener in our patients. And so incorporating the trauma-informed approach in that screening was really something that they were very interested to learn more about and eager to incorporate in the process. So we thought that that was a really to get that part of the within social determinants of health. And then post-COVID was another example of the clinical teams constantly being exposed to the trauma of dealing with patients and working through their feelings with serious trauma. We felt like it was important we were able to include trauma-informed care and development plans. So that was another area where we were able to engage and educate additional departments across the system, whether it was HR or quality, and get buy-in in that way.
Okay, great. I want to see if we can squeeze in maybe another question, if you all can just hang on with us. So there was, seems to be some interest in some of the trainings that you all talked about. Is any of that training available in 2021 to other people outside of your system? And if so, how might people go about reaching out to you all? If there are significant challenges with accessing that training, then I think we'd also be interested in probably sharing back after the webinar and other places that people can go to identify training. So is your training available in 2021, and how do people sit in your audience if so?
Yeah, we've actually been talking about maybe having kind of a library of some virtual trainings, although all of us really feel the importance of in-person or at least some type of virtual supported type of training. So it's not necessarily just watching a video speaking about this. So some type of hybrid of it is actually one of the projects we had discussed working on. But I think all of us, Judy and Jen, have an ACEs-based behavioral health and clinical training. I have a training that's maybe a little bit more focused on clinical staff, medical staff, that includes providing a trauma-informed exam when there's actual physical contact between patients and clinicians. So it just has a little bit more on that realm. And I think, at least I can speak for myself, I feel comfortable with sharing trainings, or that's why we left our contact information for people to reach out for us. I know as part of the Cook County Human Trafficking Task Force, my training's actually already been shared at meetings last year to people that came into that task force, which really covers law enforcement and social work and programs really across the city and into the state and beyond, visiting and learning about trauma-informed care. So
great. I saw another question that we may be able to respond to pretty quickly. Between the two initiatives, and because we did mention that time and funding are challenges, could you just make sure we're clear on whether or not your teams are convened by staff within the hospital, or if you're working with trauma-informed consultants?
I can start with us. I mean, our team is comprised of staff, the kind of big multidisciplinary staff that Hannah mentioned in the beginning across our clinics and throughout our health system. But we have partnered with you guys have given us some good resources and helped us with training. So we have sought your advice and expertise as well. But the sort of core group here is all staff members.
Okay. And on Northwestern,
talking a lot. I guess I'll say one more thing about that. I would say, a big component of the work involved in community health was based on the needs assessment. So that was very much a community-based involvement in that decision and importance of violence reduction and community safety. But moving forward in the context of potential expansion and goals for maybe having a trauma-informed care model site, which right now is still a little bit of a pipe dream, but something, we always try to think big here, is engaging basically a community group, a very highly aware group of individuals who experienced trauma from some of the communities that we serve. So, not completely formalized, but definitely will engage as we move forward with future projects.
Great. So I think we've actually gotten to the end of our questions. I want to again thank you all not only for presenting, but for staying over. And thank you to our audience for staying over a few extra minutes with us. I'm going to end our discussion and then turn it back over to Madison to close us out. But before I do that, I also just want to say thank you to the panel, as well as to the ACEs team for allowing me to present. And I just want to acknowledge that Dr. Audrey Stillerman is our very capable and actually quite brilliant co-convener for the Trauma-Informed Hospital Collaborative. We just want to thank her also for her work offline to help the webinar move forward. Madison.
Thank you, Marlita. And yes, thank you also to Audrey and to all of our panelists. Thank you all so much for these great presentations and for sticking around. And thanks to those of y'all who were able to stick around with these questions. We will be putting a recording of this on our website, and we will also be following up with all of our attendees with links to that, as well as some of the handouts mentioned, PDFs of everything you've seen today. So please watch your inboxes for that over the next couple of days. We'll also make sure to have everyone's contact information in that email. So if you saw something or heard something that you really want to talk to our panelists more about, please reach out to them, or of course, myself. Thank you again to all of our great panelists for these presentations, and to all of you for attending, and have a wonderful day. Thank you so much.